students, welcome to the EGVRS tour around the retina world in 30 days. In this tour, we will get to meet the stars of the retina and vitreoretinal surgery around the world. We will get to know more about their personal life, their success stories, the challenges they meet, their dreams, and more and more. For 30 days, we'll roam the Mother Earth, exploring the retina world around us, communicating and learning from each other, not only about retina and vitreoretinal surgery, but also about the wisdom of life. Our stop today will be in Europe, and we shall land in Denmark and meet our great professor and my mentor, Professor Michael Larsen. How are you, Michael?
I'm fine, thank you. It's an honor to be among you during the Ramadan. I feel like an honored guest, and I'm thinking of my colleagues here who will be enjoying Ramadan at the same time as you, but here in Denmark.
Thank you, Michael. Let's have a tour in some of the social aspects of Professor Michael Larsen's life. My first question to you, did you dream one day of being a doctor, or you dream of something else?
Well, I thought my first dream was to become a marine biologist. So I was scuba diving at the beach, and I thought I was looking at the great films of Jean-Jacques Cousteau, the ocean explorer, who was in my childhood a very famous man and one of the first ecologists. And from then on, I did a lot of swimming competitively, so I was a lot in the water. Then my first encounter with anatomy was because my father and my grandfather, they were butchers. So I was working, I was working in their shop studying anatomy, and they said, "What are you doing? Chop, 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 chop." Well, I got to see where this nerve's going. When I was preparing for my high school exam, I thought about, well, I'm not sure what grades I'm going to get because I've been partying too much. So if I get top grades, I'll study medicine. If I get secondary grades, I'll study economy. If I get the lowest grades, I'll study engineering.
Okay.
But thanks to some good fortune,
you got the highest grades. Okay.
Maybe I would have had a better life as an engineer, but I'm satisfied.
Okay, it's nice that you are not now a butcher.
Well, that's a tough job, you know.
Okay. Okay, my second question to you, where did you study medicine, Michael?
I studied medicine in Copenhagen. So there are 3 medical schools in Denmark. It's a small country with now almost nearly 6 million inhabitants. But we have 3 medical schools, but the oldest one is Copenhagen. And for the place that I grew up, Copenhagen was the place to go to. So I went to Copenhagen.
So Denmark now is just 6 million?
6 million.
Okay, we increased 14 millions this year.
Yes. Sorry, man.
Okay.
Well, you're strong people.
Okay. How did you end up being an ophthalmologist and retina specialist, Mike?
Yeah, the way it happened was that I was going to surgery. I went to the operation theaters to study surgery, and I had the problem that it takes so long to get the patient under anesthesia if they need anesthesia. There's a lot of preparation, and then you sit in a dark room, and so I tended to fall asleep, whereas I thought it was much more fun to follow people like Alan Burt, Don Gass, and Larry Iannuzzi, who were looking at fluorescein angiograms and fundus pictures and ERGs and trying to figure out why people have poor vision in some conditions where even the retina may look normal, yet you can't, there is definitely something wrong. So you have to use all these fancy psychophysics and methods of examination. And that inspired me to try to do the same in Denmark, because I was looking around and there was no one who was doing the same level of subspecialization. So I sort of decided that, or I figured out that it must be coming to this country as well, because we have to go more in depth. We have to become a lot wiser, smarter when it comes to making good diagnosis. So I thought I'll specialize in making diagnosis, and I'm going to do the surgeons a favor, the ophthalmic surgeons. The favor consists of getting out of their way, and secondly, taking a lot of difficult patients with me that you don't have time for if you have the responsibility for doing surgery and all the pre and post-operative care that is needed, being on calls at night and so on. So I think that made me popular, and it was a good solution for patients and colleagues as well. And then I had the insight from going to international meetings that medical retina is probably going to grow a lot in the future, because photodynamic therapy was going through preclinical trials, animal studies, and so on. And they were even talking about, this is the late 90s, about something called RuFab, a modified antibody that is supposed to going to do something against neovascularization. So this was a precursor of the molecule that eventually became Lucentis.
Yes.
And third factor, fundus imaging was becoming digitized. So now, instead of waiting for film to be developed, we could examine patients in one go, doing fundus photographs and angiograms on the very day that they arrive, and finishing and making diagnosis.
Life become easy.
Yes, and we were getting ready for fast track treatment.
But where do you have your training, Michael?
I just want to mention one more thing.
Okay.
OCT was also.
Yes, OCT was coming. Yes.
So I got my training in hospitals in the greater Copenhagen area.
Okay.
That's where
so you want to not only one hospital, many hospitals?
I've been working at 4 hospitals.
Okay.
And the interesting thing is that we have merged them all to one big department. Because
okay. My question is about the ophthalmology practice in Denmark. Do you see that there is some changes happened during the last years, and what the challenges did you face in the last years?
So after we merged all departments in Copenhagen, which has 1.6 million inhabitants, we could subspecialize seriously, so that for every subspecialty team, like for instance neuro-ophthalmology, which is not a big subspecialty, we have 3 full-time doctors. So there's always someone at home, 24 hours a day. You can get the highest level of subspecialty service if you're a patient in Copenhagen. And that has been what we aimed for, and it's wonderful. Secondly, we have a very serious and very streamlined postgraduate ophthalmology training program. It wasn't nearly as structured when I was being trained.
And I was the first one to get training from it.
You were one of the first and one of the best research fellows.
Okay.
We had more freedom with you than we have with the 5-year block people who come in, And that's very, very rigorous. They go through a rotation in all subspecialties.
Okay, okay.
And they even take an exam, the European Board of Ophthalmology exam, although it's not compulsory in Denmark.
Okay.
It is de facto compulsory for our interns.
But now you have one merged department supervising all ophthalmology in Copenhagen?
Yes. And in addition to the ophthalmologist, the ophthalmology that we're doing at this department, we have private practice ophthalmologists.
Okay.
And they mostly do general ophthalmology, those who are under full-time under the public healthcare system. And then there are a few clinics who do full-time cataract surgery and only cataract surgery.
Okay.
But they do it either privately. Some people have private insurance. It's a minority, but they do exist. Or they do it under a contract where they subcontract things that we are farming out from the department, because cataract has a very high volume.
Okay, let's go to something away from ophthalmology. I would like to ask you about your hobbies, your favorite places in Denmark and outside Denmark, and your favorite food in your country.
Well, of course, my favorite place outside Denmark is definitely Egypt.
Yes, yes.
After I got to know you, so and met the nice people of Egypt, and then with my family, we mostly have vacation in Denmark or one of the neighboring countries. Okay. So there are nice beaches here. The summer is wonderful, and we have big mountains and huge forests in the neighboring countries of Sweden and Norway. And then in Germany, we have wonderful old cities with great houses, cobblestone streets, and so on.
And your hobbies nowadays, did you change your hobbies? Swimming in the very cold weather, as I saw before?
I have a new hobby. Okay. So my new thing is that, well, it's an extension of my love of crafts and skills, okay, and doing practical maintenance procedures and so on. And so I have bought a farm. I've bought an old disused farm on an island. Okay. Here in Denmark, and
I didn't visit it yet.
No, you have to come. Okay. There's a beach. We're going to have our own beach, Suleiman, and there'll be place enough for 100 visitors. 100 visitors, yes. Okay. Once upon a day, I will visit your new farm. Yes, and bring all your friends with you.
Okay, thank you. Okay, let's ask the last question in the social part in our meeting with my great professor, Michael Ars. What's your dreams for the future, Michael?
I'm hoping that we can do more in the future for the remaining big problems in ophthalmology. As we see it in Denmark, it's the hereditary diseases, and especially the hereditary diseases of the retina. So we're working very hard trying to carefully identify and characterize patients with hereditary retinal degenerations. It's retinitis pigmentosa and all kinds of other diseases. And we're preparing registries of families with careful clinical diagnosis and staging and molecular diagnosis as well. We have the fortune here that we can get a molecular diagnosis, a very advanced one, on every single patient. And this is great for enrolling patients and participating in clinical trials of gene therapy. So that is our main focus.
And what's the dreams for yourself?
Well, for myself, it is to retire in good shape and look back at a lot of PhD students who
Okay.
have taken over and who are lifting ophthalmology to an even higher level than I was
Okay.
able to do because I was standing on the shoulder of giants.
Okay. Okay. It was very nice as this social part of the meeting. And I think now we will enjoy the scientific part of this great meeting with my professor, Michael Larsen.
Today's topic is the Feroxamine Retinopathy. How can we understand it? The background is that repeated transfusion in people with bone marrow failure leads to iron accumulation and hyperferritinemia. Iron chelation therapy is needed to avoid fatal ferrotoxic heart and liver failure. The reference chelator is deferoxamine, which was developed in the 1980s under different standards than today. Degeneration of the outer retina can be seen in people on chronic blood transfusion therapy. Such retinopathy was never reported before deferoxamine was introduced, when people died early from iron toxicity. So, proactive surveillance of retinal complications in anemia is uncommon, strangely. Before we go to anemia, let us look at hemochromatosis, where iron accumulates due to an abnormality of absorption. And here the problem can be solved by phlebotomy. And these patients therefore never need iron chelator therapy. But if you look at their retina, they can develop a degenerative outer retinopathy, as we see it here with the abnormal autofluorescence images and the OCTs showing abnormalities and irregularities in the outer layers of the retina, photoreceptors, and pigment epithelium. The solution to iron accumulation in chronic anemia is iron chelation therapy with medications. Deferoxamine treatment is given by subcutaneous infusion over 8 to 12 hours on a daily basis for 5 days per week. For prolonged periods, it's a very burdensome kind of therapy. Deferiprone and deferasirox are oral alternatives that are more costly. Their ocular side effects are not known or have not been reported so far. Chelators enable iron excretion in urine and feces. Iron accumulation is monitored clinically by measuring plasma ferritin, and the therapeutic target is to have plasma ferritin below 1,000 micrograms per liter. Deferoxamine has been a tremendous clinical success. The survival of children with thalassemia can be seen here, and it has decreased tremendously since deferoxamine was introduced. This is the first case I'm going to show you today. It's a man aged 72 who's had blurred vision for 1 week. His visual acuity was 0.6, 0.9 before this event, and now it's down to 0.3 in both eyes. And he has got this serous macular detachment in both eyes. This is the fundus photograph in color, and here the green channel and grayscale rendering. And this is what it looks like 1 year later. It has progressed to outer retinal atrophy. And we can see that more prominently here in the autofluorescence image on the left and the OCT on the right. There are areas of the photoreceptor RPE layer where no pigment epithelium seems to be present at this point. The visual fields are severely damaged, and the autofluorescence image is highly abnormal. On the lower right, you can see a transitional zone recorded by adaptive optics fundus photography, where photoreceptors are missing or very scarce. To the left, in the foveal center, and they're intact to the right extreme, and there's a transition zone between them. And here is an interesting curve, a kind of curve that has never been shown in the literature so far. It shows over several years the course of change in the most important biomarkers here: ferritin, creatinine, C-reactive protein, and hemoglobin. And you will notice that sometimes before the patient goes on to develop visual disturbance, he has pulmonary edema and fever, and this is a response to antithymocyte globulin therapy, an intravenous therapy that destroys a lot of thymocytes and induces a cytokine storm. The infection comes next here. That was a pulmonary infection, and here sepsis. So there's a lot going on, and there are spikes in CRP as well before he develops his visual problems. Next case, male, 73 years, myelodysplastic syndrome for more than 5 years. He gets weekly erythrocyte suspension transfusions. His plasma ferritin is all the way up to 10,000 micrograms per liter and has decreased gradually over the course of his disease. It's peaking near the onset of visual loss. He's got blurred vision, dyschromatopsia, floaters, flashes, and visual acuity 0.2 in both eyes. Feroxamine was discontinued, and visual acuity improved to 0.8, 0.5. Here are baseline autofluorescence images to the left and OCT to the right, and then follow up 3 years later. And you will notice that not only did visual acuity improve, there was also a disappearance of a lot of hyperautofluorescent material. And in the photoreceptor layer and the RPE layer, you can see that considerable restoration of photoreceptor outer segment, length or height if you want, happened over those 3 years concurrently with his improvement in visual acuity. So here, very fine visual fields compared to the other patient. And here another curve showing biomarkers, the gradual rise in serum ferritin. That means higher and higher accumulation of iron despite therapy with chelators. There are spikes in creatinine and in CRP long before he develops his bout of visual acuity reduction here. So here's more detail from the acute phase, where we have control OCTs on top, and then the 2 cases with severe irregularity of the macula photoreceptor layer and pigment epithelium layer, and a more intact periphery. There's a highlight of this area right here. Definitely very dramatic abnormalities. And so case number 1 goes on to complete outer retinal atrophy and profound visual loss, whereas case number 2 shows survival and restoration of the photoreceptor layer. Very interesting contrast. Conclusion. Feroxamine is strongly associated with acute visual and auditory dysfunction. We didn't mention auditory, but it also happens. Adverse effects occur in the retina, optic nerve, and inner ear. Damage to the outer retina occurs in an acute and a slow form. In our case of isolated outer retinal disease, the relation between ferritin, the chelators, and systemic infection and the visual loss was very complex. The retinopathy seen in our patients resembles the retinal siderosis seen in foreign body injury and hemochromatosis. That's thought-provoking, because you get to ask yourself, maybe iron is a culprit here, or a co-culprit, and not deferoxamine, or maybe they're both involved. So we propose the hypothesis that iron toxicity contributed to the development of retinopathy in our patients. So, in summary, for the clinical retinologist, it is common practice to suspend iron chelator medications when patients present with acute retinopathy. And it would be problematic if you don't do that, I think. And recovery has been reported over 2 to 3 weeks. Then the next thought is that maybe these patients were not treated enough with chelators. They were not treated early enough and for long enough, because they were allowed to go way above treatment target. And maybe that also contributed to what happened in their retina. So, in summary, we urge you to take good care of your chronic anemia patients who are receiving chelators, or who are in a condition where they're soon going to need chelator therapy. Thank you.
Michael, I would like to ask a question. Do you think that deferoxamine retinopathy still exists, or is a right name?
I think there is a lot of confusion and maybe even some serious misunderstanding. I question that deferoxamine retinopathy exists at all. I strongly suspect that what has been called, and is still being called in many places, deferoxamine retinopathy, is actually an iron toxicity resulting from the very high concentrations that many people with chronic anemia have of iron in their circulation. It's a huge problem. If you look at the documentation, there's no real evidence that deferoxamine retinopathy exists, but there's a lot of evidence from basic science and from clinical observations that iron toxicity is something that is very bad for the retina. We know this from cases of traumatic injury with retained foreign bodies. It looks the same as what they call deferoxamine retinopathy. We can also see in hemochromatosis patients who have never received any deferoxamine a similar retinopathy. So I'm afraid that we're doing something completely wrong, and the hematologists maybe have been scared into not using deferoxamine enough the way it should actually be done. There are other iron chelating agents. We don't know if they are any better or any worse, but I'm afraid that the deferoxamine scare sticks to all of them. So we should really do something serious about writing up new guidelines and doing prospective studies. And it can easily be done. When deferoxamine was invented and introduced, that was in the 60s. People were dying from cardiac disease at a young age because of chronic anemia with the need for repeated transfusion. They have been rescued. They now survive. But there hasn't been a deferoxamine trial ever that was prospective and had an ophthalmic endpoint. It's about time we do it. I hope you can contribute with patients from Egypt and investigators.
Okay, thank you. It was a very great presentation, and thank you for this great meeting. And I hope to see you in Denmark and also in Egypt in a very good health. And I really enjoyed this meeting, and I hope to see you soon, Michael.
Okay, and have a nice continued Ramadan. Enjoy yourselves with your families and friends. Stay healthy.
Okay, bye-bye.
Bye-bye.